This is a 56-year-old Hispanic female stating that she has been having palpitations on and off for the past few months. She also reports increased shortness of breath. In the ED, her EKG showed atrial fibrillation with RVR with a rate of 126. She did receive 5 milligrams of IV cardizem, which converted her to sinus rhythm, and now she's in a rate of 85 beats per minute on the telemetry unit. She denies ever been told that she's had atrial fibrillation in the past. However, she was placed on blood thinners and beta blockers while in Mexico City in 2002 for an abnormal heart rhythm. Although she denies taking any daily medications at this time, um, thus the cardiology consult. She does have a past medical history of hyperlipidemia, hypertension, anxiety, fibromyalgia, and an unspecified abnormal heart rhythm. She does have a surgical history of C-section in 1995. Um, she does have multiple drug allergies, which include sulfa, clarithromycin, caffeine, codeine, and morphine. Again, she denies any daily medications. Um, in regards to the review system, she denies any chills, fatigue, generalized weakness, lethargy, or recent weight loss. No visual changes, no headaches, no loss of consciousness, no dizziness, no trauma. Respiratory wise, she does report dyspnea with exertion and shortness of breath, denies hemoptysis, cough, pleuritic pain, or pneumonia. Cardiovascular, she does um, report dyspnea and exertion. She does have palpitations on and off. Denies chest pain, edema, or heart attack in the past. GI, good appetite. Denies abdominal pain, constipation, diarrhea, nausea, vomiting or a GERD. GU denies dysuria, frequency, hematuria, nocturia. Musculoskeletal, she does report having some fibromyalgia. Um, Neuro-wise, denies any bowel dysfunctions, confusion, dizziness, focal weakness, headache, lightheadedness, numbness, seizure, slurred speech, or vertigo, or even syncope. Um, she does have a report of having a history of anxiety, but she denies any recent episodes. On physical exam, she's a 56-year-old Hispanic female, alert and oriented times 4. She follows commands appropriately. No acute distress noted. Current vital signs of BP of 135 over 83, heart rate of 75, SpO2 96 on room air, oral temp 35.8 Celsius, respiratory rate of 20 per minute. HENT, atraumatic, normal cephalic, Perla, normal nose, normal pharynx, full range of motion in the neck, no JVD, normal thyroid, no bruit in the carotids, no masses or swelling. Cardiovascular, regular rate and rhythm right now. BP and pulses equal bilaterally. Normal heart sounds S1 and S2 heard. No murmurs. Respiratory wise, she is cleared to auscultation in all lung fields. No distress noted, no retractions. She does have a symmetrical chest movement. Abdomen, non-tender, normal bowel signs times 4. No distension, no guarding, no pulsatile mass, no rebound tenderness. Upper extremities, normal capillary refill, normal temp, no clubbing, no cyanosis, bilateral radial pulses 2 plus. Lower extremities, normal capillary refill, normal temp, normal no edema noted, bilateral 2 plus pedal pulses present. Most recent lab works done during this admission: sodium 142, potassium 3.6, chloride 104, glucose 132, BUN of 13, creatinine 1.0, WBC of 10.5, hemoglobin 14.8, hematocrit 44.5, platelet 275, PT 12.6, INR 0.93, PTT is 30.9. They did obtain one troponin. Troponin I is 0.01. The EKG interpretation The one from admission in the ED was the atrial fibrillation with a ventricular rate of 126, which was then converted to sinus rhythm at a rate of 84 after the cardizem administration. Current EKG interpretation is sinus rhythm at 85 beats per minute, no ectopy since she's been on the telemonitors. My impression is atrial fibrillation with RVR. However, she's currently in sinus rhythm. 2 is dyspnea, 3 hypertension, 4 hyperlipidemia, 5 chronic pain. Differential diagnosis includes atrial fibrillation due to the abnormal EKG obtained while the patient was in the ED. Patient also reported having an abnormal heart rhythm and was previously placed on beta blockers and blood thinners in the past. Patient also reports having palpitations on and off in the past as well. Atrial fibrillation can also cause the dyspnea, especially with exertion, which is consistent with the patient's symptoms. My second differential is pulmonary embolism due to the new onset of dyspnea and atrial fibrillation. Patient reports having an abnormal heart rhythm since 2002, however, has been non-compliant with blood thinners and beta blockers. She does report having palpitations on and off, which possibly mean that she is constantly going in and out of atrial fibrillation. This increases the potential of causing a clot to be pushed out of the right side of the heart into the lungs. My plan for her, one is the CTA of the chest to rule out a PE in view of the new onset of atrial fibrillation and dyspnea. Number 2 is obtain an echocardiogram to view the function of the heart, see if there's any abnormal wall movement or abnormal valvular dysfunction. 3, I'm going to start her on Sotalol, 80 milligrams PO BID for arrhythmia. 4, I'm going to start the Xarelto, 20 milligrams PO for DVT PE prophylaxis. 5, I'm going to obtain some labs in the AM, including a repeat of CBC and repeat BMP. I'm going to add some cholesterol levels as well. 6 is a nurse communication to have them obtain an EKG strip if the patient reports any chest pain or palpitations during the hospital stay. Cardiology will follow the patient closely throughout the hospital stay, as well as wait for the CT and echo to be obtained to have those read. In summary, the patient presents with a new onset of dyspnea and palpitation. EKG was interpreted as AFib with RVR at a rate of 126. The patient reports having a history of abnormal heart rhythm, however, is unspecified, and patient has been non-compliant with medications. For the patient wasn't able to state for how long she hasn't been on the medications. Patient is currently in sinus rhythm since she's been on the telemonitors during this admission. Due to the new onset of dyspnea and palpitations on and off, the potential of PE is a factor. Therefore, the CT of the test will be performed. Also, an echocardiogram, as discussed earlier, will be done to view the heart function and to see if there's any abnormal wall motions or abnormal valvular motion. New medications will be started, as stated earlier, for the arrhythmia and DVT PE prophylaxis. And the repeat labs and cholesterol will be obtained in the morning. Cardiology will follow this patient closely throughout the hospital stay.